We're living through one of the most important inflection points in the history of medicine. For the very first time, intelligence itself is scalable. And the question before us is not whether AI will change the healthcare, it already is. The question is whether we can use it to create better decisions, better clinical flows, and ultimately better outcomes for the patients. That's why we are all having this discussion in all these rooms. We have spent last century scaling this healthcare through hospitals. Yes. Are we about to spend the next century scaling the healthcare through intelligence is what we are here to discuss. And who better than both of you to answer these questions? We have Peter here, who is a physician who has spent his entire career asking a critical question: how do we use technology not just to collect more information, but to make better clinical decisions? Today at Google Health, you're helping shape the future of AI-enabled healthcare. Thank you, and we are delighted to have you with us. And Mr. Srini, you have spent decades leading large-scale technology and transformation programs, and AI moves beyond just a buzzword to business today. Few people are better positioned to discuss how organizations and people can successfully navigate that change, and today we have you. I have more interesting questions for both of you. So we'll start with Dr. Peter. Yep. So let's go for it.
You promised to ask Srini the hard questions, so just easy ones for me.
I promised him the most easy ones. I promised him already, sorry. For Peter, every decade promises to transform healthcare. AI seems different. What is a single capability AI unlocks that physicians have never had before?
Great question. So I think the question I might invert slightly, which is that AI shows enormous promise, but it's only valuable when it is linked into a workflow that brings value to a patient. And so sometimes I think we often have a cart-horse problem. We expect AI to do amazing things in general, but the actual answer is that it can solve very specific problems, and it's important to be very specific about the problem you intend to solve so that you know that it's getting better and that you know that the change is an improvement. And so I think perhaps there's not one single answer, but I think what I would say is the two things that are most valuable for a clinician. One is time. And so I think a lot of time spent by clinicians has high cognitive load, but low cognitive value. I described this when I was an ICU doctor. You might admit a patient, and in the US we have very bloated medical records. Sick patient, 1,000 pages of medical records, 2,000 pages of medical records. About 15% of US medical records are longer than the novel Moby Dick. It's really hard to sort of do justice to that amount of data in a short interval. So I think one value, and this is sort of a simple one, is sort of time, so that your attention isn't on high cognitive load tasks that are low thinking value, but rather the thinking that you do is highest value, is sort of the best, most important sort of clinical decisions that you would want a human to make, as opposed to physician as data mule moving information from one system into another. I felt like that a lot when I was a doctor. So time is an easy answer, but I think a better answer is attention. We are very distracted as a community, as people, but as doctors, your attention is constantly distracted. And so I think when you look at things like Ambient Scribe and other tools that have allowed attention to be turned away from a screen or a computer and towards another person, that actually is probably one of the most important things. That the best trick AI can pull is becoming invisible and then giving back time and that quality of attention.
That's very thoroughly put. I think most of the times people who are building solutions do not know what the problem they're solving. What is the problem they're solving? They build the solution and search for the problem, even if that exists or not. We often see that. And since I'm a physician myself, and I have been in those shoes of integrating the reports and interpreting them just to intervene the condition, right? So I don't think doctors should spend their cognitive value and time in data collection or data interpreting. That is not their job. I think it's very valid point to find the flow, to value the time of the clinician, and they better spend their time and value in making the decisions, better clinical decisions for the clients. And here is for Srini. AI is advancing exponentially, and who better than you would know that. And clinical adoption also is moving pretty linearly. What is the biggest bottleneck today about either adoption or even usage? Is it the regulation, reimbursement, or the mindset in the healthcare, or the technology itself?
Thank you for the question. Thanks for having me here. It's a privilege and honor to be on stage with both of you. By the way, I just learned that Dr. Satya is a celebrity in Hyderabad, so I didn't know about that until I got here. So question on, when you say adoption, for me, sorry, question on adoption. Typically, it's not about the technology, right? We've all seen this movie play before. Technology promises a lot of things. There's a plateau, there's curves that we all track on how they evolve and get adopted. It's typically culture. Are people willing and able to change the ways of doing things? There's a lot of legacy. People are wedded to a certain way. Change is always hard. And what's in it for them? And what's in it not for the person who's using, but for the end, in this case, the patient, right? What's the value that we're driving? I'm sure regulation, AI regulation is coming. Look, in this case, governance, explainable AI. There's all kinds of, a clinician is always, the judgment of the clinician is always going to be. Okay. No worries, I'm done.
Unless it's very boring.
Not for us. No, that's okay. So for me, the barriers of broader adoption is, are we solving a point solution? Are we solving, it's like losing the forest for the trees type of thing. Sometimes I see, again, a lot of talks we see is, I'm solving one problem. I just said, fall in love with your problems, not your solutions. Like, don't be a hammer looking for a nail. I believe we're going to create a lot of tech debt in this agentic space. Everybody is creating agents. Like, what's the governance around it? You will have thousands, every institution will have, everybody's able to write agents now. So if you kind of look ahead a year from now, that adoption curve is going to plateau, and we will be resolving tech debt that comes with AI. I hope we don't accumulate a lot of AI debt in organizations, and that's the risk I see in adoption, because once you have that, then it proliferates, there's no governance, there's no control, and trust. If you don't trust it, it becomes a much more challenge. It's going to be, I always say trust arrives on foot and leaves on a horse or a tweet nowadays. So if you don't, if you don't make sure you're intentionally designing trust, especially in clinical systems where doctor is a god, and if judgment is outsourced to AI, it's going to be problematic.
I don't think AI is going to replace doctors, because we have stethoscopes which never replaced but only augmented us. We have imaging that again augmented us, it never replaced. And also AI is going to augment the similar way, and we do not know how it's going to augment better and more in the future. But clinical judgment is always going to be there.
Yeah, absolutely.
Yes. And next to Peter again. In medicine, being wrong has consequences. How should clinicians think about AI outputs? As an assistant, as a colleague, or as a junior trainee, that requires supervision, right? So this is going to be a discussion around trust and validation again, but I want to hear from you.
Yeah, so it's a really interesting question. I think it's one that we're really only starting to understand in its more modern formulation, because the tools change so quickly. And I think some of the pitfalls or problems have evolved really fast. I think that one of the things that is really hard to understand exactly how to teach, but I think clinicians in the room will recognize, is that there's a saying in US hospitals and maybe here as well, which is trust but verify. Trust but verify actually applies to an era before AI. And what the expectation was, and I'll date myself by saying as a trainee in the late 20th century, trust but verify meant that if the emergency room told me the EKG looked good and the chest x-ray was clear, I'd say thank you. And I'd look at the EKG and I'd look at the x-ray because I trust my colleague on the phone and I'm going to verify the primary data myself. And so it's difficult because there's so much data, and it's also difficult because the outputs that we see are incredibly fluent and lucid, and they sound right. So I think one of the things that's getting very, very hard is to maintain that cat-like vigilance of trust but verify all the time when what you're seeing is really good and very fluent and getting better. So I think that's going to be a real challenge for how you have to train your eye and your ear for the things that don't match what you're seeing. And I really think that that quality of discernment, which has always been part of medicine, becomes a quality of discernment in using a new tool. I'll give you an example. I trained before bedside ultrasound was in wide use in the ICU. And then one day when I was a grown-up doctor, like no one was there to teach me, and ultrasound showed up in our ICU and sort of poked at it. And it was very clear right away that it was a very powerful tool, but you needed training. You needed to understand that it had artifacts, that there were things that might look like a vessel but were really just a void behind a bone or something. So it was a process of learning the tool and getting comfortable and having a quality of discernment about how I might use that in my practice. And I think things are moving very fast, but I'd still say trust but verify is really important. And I would still say that the thing that the human brings is that quality of discernment and it requires vigilance. And I think it requires practice, but I think that those will be some of the skills that will be important as we incorporate more of these tools into our daily clinical lives.
I agree and resonate with you on this about trust but verify, because trust and verify, to be more precise, because even in a day where internet is not working, the clinician should be able to make a judgment of their own. So that is where medical students will always go through the traditional model of training. They should be able to palpate, percuss, auscultate, listen with a bare minimum stethoscope before moving to augmented stethoscope as well. So the basics will never move out because empathy is always should be there, because that is something AI cannot replicate. So yeah, trust and verify. Moving to.
Thanks, Shuman. You can always listen, trust, but verify. And when you say and
Trust
verify,
and, yeah,
Trust
I think
and
it's-
verify.
way to-
Yes, yes. Srini, again, the question to you. Every industry eventually learns that technology alone doesn't create transformation, right? Culture does. I was asking this question while we are having lunch. What lessons from large-scale digital transformations apply to healthcare today when we talk about culture?
Yeah, so honestly, I had the privilege of leading several large transformations in Fortune 20 companies, Fortune 100 companies. There's a common theme that I've learned across this. Transformations are hard, and it's called transformation, right? Not modernization. Transforming yourself is hard. A couple of common threads. Obviously, culture is a key part, right? Change management, all that. I would say the top three things. Thanks for the heads up from that. Got me some thinking time. One is, are you installing I've seen people call transformation, they're just installing new software. That is not transformation. That is, you're installing a new way of doing things with a new tool, right? So you got to decide whether are you redesigning things? Are you challenging how jobs are done in an organization, workflows? Because you can optimize the wrong thing, and I'm an engineer. You give me a problem, I will optimize the hell out of it, but it may be the wrong thing. So that leadership philosophy that this is not just a like-to-like or a new tool or a new something, like you're challenging how jobs are done, how workflow is done, and that's the hard part, because I always say nobody gets fired for optimizing, because it's efficient, it's measurable, it's fundable, because you're generating cost savings, things like that. Redesign is hard because it's not easy to measure your different ways of doing things. It takes hard work. So the leadership commitment on the choice on redesign is always the part. Then I would say every organization has something that is scarce, expertise, and that was my theme of the talk yesterday. What is the new scarcity you are creating? Because not everything is abundant. Maybe the transformation makes one scarce thing abundant, but what is your new scarce thing? Like in this case, let's say if intelligence becomes scalable, that's augmented, you're augmenting every clinician. What is the new scarcity that you got to design around? Because you always, an institution exists to design around scarcity and optimizing that scarcity. Is it judgment? Is it clinical judgment? Is it the trust? So we need to be clear on, in any transformation, I'm tying it back to healthcare, what is the new scarce resource after you transform? So you're optimizing to the new scarcity, right? And then the common things around like having people on board. I mean, this is like change management playbooks. Any management consultant can tell you, having change champions and kind of ground up, right? Making sure people understand, and the stakeholders, not just the users and end users, how it's going to be different. So those are a few things that come to me.
It's nice. This is my favorite question. I've asked you, and this for everyone who are waiting for the answer. Imagine a medical student graduating in 2045. I moved them a decade apart. My initial question was 2035, but I want 2045. What should they spend less time learning, and what should they spend more time learning?
So I'm glad you gave me a little time to think about this one. And I will also say,
You had a leaked question paper, understand?
10 years ahead was difficult. 20 years ahead is really difficult. But let me try and say something about what I think. Let me work backwards in time. So when I was in the late 20th century applying to medical school, and when I was in medical school, the discernment or the differentiation between me and Srini or whoever the medical student next to me was really based on memorization and ability to take standardized tests, right? And that I was evaluated, if I knew 9 causes of hypercalcemia and Srini knows 7, if I know 9 off the top of my head, then that must be a better doctor. Now, I actually don't think that doctors as kind of memory banks, that doesn't really fit today's reality, partially because the amount of information has exploded, and partially because there are other tools for certain kinds of things. If you ask medical students now to name causes of hypercalcemia, they'll look it up and read them off. And that's probably a pretty good way of doing that. So I think we've moved away from sort of the core differentiation is memorization and the ability to hold things in your brain. And I think now you might say the core capabilities that we really look for are the ability to synthesize and integrate. The language of medicine is multimodal, you know, the ability to take all of these different signals and integrate them into a cohesive plan, much more important than memorization. Now, at the same time that I say that, the tools that we're developing are getting really good at organizing complex multimodal information and sort of helping to point towards a diagnosis or even a treatment plan. But I actually don't think that that's enough. I think most people would say they really want a human interaction to talk about their health and their disease. And so you can still see a place there, but it's a different sort of role. And so if I was sort of thinking about what are the 2 things maybe that you would teach medical students now or in the future to really focus on? The first one is perception. A lot of what you learn is how to be a good perceiver, that you listen, that you attend to the details of the physical exam, that you pick up on things. And so I think we could do more, because I think good doctors tend to be very perceptive. And I think that that's something that's teachable and learnable. And I think that the other thing that I would spend time on is perspective. Even if you're a great perceiver, if you lack the ability to take on the perspective of the person on your team, or most importantly, the person in front of you, you're going to lose something in that interaction. And so I think that the dual abilities of perception and perspective are probably the two things that are most elemental to where the human brings value in a world where summarization and organization and coordination of certain kinds of information is getting to be the sort of thing that not only that AI can do, but AI can probably do better 20 years from now than even the best calibrated human brain. So I would focus on things like that.
I wasn't expecting this answer, and this perspective is very important. I would like to add one more thing towards perception and perspective is learning to empathize with the individual. It's very important. The other day I was mentioning, Bhavya, about how needs and wants of the individuals have changed now. What we think is the need of the hour for the client, that is to prevent atherosclerotic cardiovascular disease, which is impending right now, could be a need for me as a clinician for the patient. But patient is there in front of us wanting other thing in life. That want could be increasing an hour of sleep, improving the gut health, or losing that extra weight on the weighing scale. So how wants and needs of the individuals have come far apart in the last few decades, before which both were same. What the physician perceived the need is the want of the individual. I want to prevent a disease, they want to prevent a disease. But that has been drifting far away now. So with that drift that is happening, perspective, perception, and also empathy are very, very crucial going forward, I believe. Yeah. And for you again, I think it's like fast fire. You can just keep it more quick.
It's a fireside.
Fireside, fast fire. Though it's around clinician, but I want to know your perspective too. If every clinician in the audience could take one practical step next week and become AI ready, what would it be?
I'm sure most of you are already,
AI ready.
without knowing, are AI ready, because it's in our lives. If you're carrying a smartphone, it's definitely AI ready. Look, I think understanding what's out there, I've seen it not just clinicians, right, in practitioners, engineers, software engineers, security engineers that I work with. The world is moving at such a fast pace. There was Fable released, and the US government stopped it on Saturday morning. Honestly, my keynote, I used Fable a little bit. But trying things, right, again, being curious. And I think that is something that I highly recommend. We talked about curiosity. And if you have 2 minutes, I'll tell a story on curiosity. It goes back to the student question, too. I tell this to a lot of my employees just to understand why it's important to be curious. There was a study done by Adam Grant, Wharton psychologist, if people follow him, incredible guy. 10 years ago, so it may not be contextually relevant now, but 10 years ago, they looked at 10,000 call center agents across companies. And they looked at what distinguishes exceptional performers from lower performers, simple things, so that we can hire better. If we know what distinguishes, we're going to look for those traits, right? These are call center agents, answering calls, solving problems, whatever. They looked at hundreds of variables, experience, expertise, skills, education, but nothing was correlating with top performers and what's driving that top performance. They collected all this data. Then finally, they looked at one variable that was correlating, and it is browser choice. So you all can sit here and say, browser choice has nothing to do with an employee's performance. So they consistently found out that people who used Chrome were higher performers than Internet Explorer. So sorry for the folks in Microsoft here. And honestly, everybody knows that browser choice has nothing to do with your job performance. But then they dig deeper, the organizational psychologists, right? And they found out that the reason why that was the variable that was driving the performance is the company by default issued a laptop to everyone, and it came with Internet Explorer. People who went out and downloaded Chrome were curious that there is a better way to do something. That curiosity translated in many ways, their SOPs, their call scripts. So the nature that there is something better out there to do my job was a leading indicator of exceptional performers from non-performers. So I want to tie it back to that. Like everyone should think that way. There is a better way to do things. And that's the only way you would know if there's a better way to do things is to seek out what's out there and play with it. There's no one magic formula. So.
Yes, I agree with you. And also, I would tie this up to what we were talking about. How the social media feed defines what kind of a person you are. What discovery feed will define what you are and what you're seeking for and what your areas of interest are, right? So yeah, curiosity. I think Peter was going to add something to that.
I'm strongly aligned with everything that Srini said. And then the only point maybe that I made earlier is we have often too much theory and not enough practice. So to sort of double down on Srini's point, it's good to read and understand and go to conferences and listen and learn, but it's important to get your hands on these tools and to start with low-risk use cases and just build it. I think it has an effect of enforcing or creating other questions and then fosters that curiosity. But the doing of things, the building of things, which the on-ramps have gotten so much easier, I think that default to making something.
So I think wanting to learn new things, seeking new things out there, and being more curious should be the traits of physician and a new student.
Finding faults in defaults was the Adam Grant tagline. So if there's a default setting, default way of doing things, default. Yes. Finding faults in defaults was the thing.
That's nice. That's interesting. And always question. Yeah. We're talking about democratizing healthcare since long time now. This is a question to both of you. Historically, world-class medicine was concentrated in few institutions. And also preventive health now. Now we have more concierge care centers for, delivering preventive care as well across the globe, not just India. Can AI democratize expertise so that a patient in Hyderabad versus Nairobi versus a small town receives guidance which is very comparable to top academic center?
So I think the answer is yes, and I think that one of the things that we're seeing as a recurring theme is leveling of information asymmetry and access to high quality information, and that's something that obviously Google thinks a lot about on search, that you get an answer that is not only authoritative but geographically and sort of appropriate to where that answer is being served. So at Google, we sort of had to struggle with things like hand hygiene recommendations in places where water is scarce are very different from hand hygiene recommendations in places where water is plentiful. So to serve, authoritative medical advice on hand hygiene that says, wash your hands for 30 seconds after every patient contact in places where there's not 30 seconds of running water for, available. That's not useful. So I think part of the question is on companies like Google that sort of need to be able to kind of create very fast on-ramps for people who have information-seeking questions about health. And I think that's really been something that has been a major area of focus. And that's both elevating good and getting rid of bad content. Would I win? No, just kidding. But I also think that what we're seeing in the US, healthcare is adopting AI at a rate higher than other verticalized industries. And that's surprising because healthcare is seen as usually kind of stodgy and a follower rather than a leader. One explanation for that is that people's use of AI for healthcare has far exceeded health system spending on AI around healthcare. And the net result of that is a leveling of information asymmetry. It was usually pretty easy to bat away Dr. Google, but when patients come armed with really thoughtful summaries and ideas and questions that they've found and they've generated on their own, that's actually extremely powerful. I think it's happening right now. I think it's spotty, right? It's patchy. That's not available to everyone everywhere. But I do think that that is the vision of kind of what these tools could do in terms of improving health on a global scale.
I think we're out of time.
Yes. I think we have had great discussion. I think I'll close with this winning thoughts today. Physicians should augment AI, and trust and verify should be the motto of them. Trying to find faults in the default systems, trying to build systems from the leadership level. Of course, healthcare is going to be scalable, equitable, and only when systems and organizations use AI thoughtfully and knowing what they're building for, try to find the solutions very precise and not find a problem for the solution. So I think we'll close it, and I think we had a fantastic discussion. Thank you both.